Assalamu alaikum. I'm Dr. Rawa Muhsin. I'm a pathologist, and I'll be talking about the role of histopathology in the diagnosis of Crohn's disease and differentiating it from its mimics, mostly the histologic mimics. So the bulk of my talk will be about the morphology of Crohn's disease. Dr. Sivan thankfully already talked about the pathogenesis, so I don't need to go into details. The current hypothesis is that Crohn's disease is a polygenic illness that results from a host immune response to alterations in the gut microbiota, and this leads to a chronic inflammatory process, mainly in individuals who are genetically susceptible. This is not one of those monogenic diseases in which you can pinpoint a specific mutation and say that it results from that. Rather, it's an interplay of different factors. The significance of knowing these genetic alterations or these susceptibility foci, as Dr. Siva mentions, the development of targeted therapies that can target any of the specific steps that are involved in the pathogenic process. Now, as I said, the bulk will be about the morphology, so I'll move to that. We can talk about the changes that will happen in the outer surface of the bowel wall, those that happen in the mucosa, and then those that we can see within under the microscope. So some of these were also mentioned by our teacher, Dr. Shahla, from the radiologic aspect. So one of the findings in the bowel wall will be thickening of the wall, and this results from the inflammation and the fibrosis. The second finding is the mesentery normally connects to one point or one pole of the bowel wall. Within Crohn's disease, this mesenteric fat will start to creep along the length or the adjacent bowel wall, and this is because of inflammatory cytokines that are released within the bowel wall. Now, it's important to know that the fat is now believed to be not just a passive bystander, but also contributing to the disease inflammation itself, as adipocytes can secrete cytokines that will further the inflammation in the bowel wall. So as you can see, this is the normal attachment of the mesentery here, while when you come up here, you see that the fat has extended further along the bowel wall, and this is what we know as, you can also see it within this portion of the bowel, and this is what we know as creeping fat or fat wrapping. It's one of the hallmark features of Crohn's disease. Another feature that we see that was also mentioned from the radiologic aspect is the development of strictures, and this is also due to not only fibrosis of the wall but hyperplasia of the muscle. So it will cause a stricture of a segment of the bowel and proximal dilatation. Now, when the inflammation involves the outer surface of the bowel wall, then they become sticky or adhesive to each other. So two loops of bowel can attach and start to develop a tract between them, and this is known as a fistula. But this can also develop between a loop of bowel and another organ or another surface, such as the skin, and that's why we have perianal fistulas in Crohn's disease. Now, what will the endoscopist see when they do an ileocolonoscopy? The earliest change are these aphthous erosions or ulcers. These are superficial, well-demarcated ulcers. The second, when these ulcers start to progress, so they become deeper, they will develop into fissures, so the ulcers become longer and they become deeper. They're known as bear claw-shaped ulcers, and serpiginous, meaning snake-like. Now, when these ulcers start to connect together, demarcating islands of normal mucosa in between them, that's when we get the cobblestone appearance. So within the cobblestone, these elevated portions of the bowel mucosa are the normal, uninvolved portions, and between them or among them are the ulcerated areas. It's likened to the appearance of a cobblestone. Finally, one of the hallmark features or gross features of Crohn's disease is that it's a segmental disease. So here we can see this portion of the bowel wall is involved. There's a stricture with ulceration, hemorrhage, and bleeding, while the segment immediately adjacent to it is normal, and the segment that is immediately on the other side is also normal. And this is one of the hallmark features that distinguishes it from ulcerative colitis. Now, what do we as pathologists see under the microscope? Well, if we get a resection specimen, we see all of the features that I just mentioned. So we see the outer wall, we see the mucosa, but we usually don't get a resection specimen. We get an endoscopic biopsy, so we don't have any of the gross features. Just for reference, this is a normal small intestinal mucosa. These are the villi. These are the normal crypts or glands at the bottom. There is minimal inflammation. This is a normal colonic section. There are no villi in the colon, so these are the normal glands, these rounded structures. This is the submucosa, and then this is the muscle. So what happens in Crohn's disease? The first thing, you can see this is a busier section than the one that we just saw. There is discontinuity of the lining epithelium. So this is an erosion or an ulcer. This is the ulcer debris right here, and there is heavy inflammation. The ulcer can start to get deeper, so it develops into a fissure. And if you go further, then eventually you'll develop a fistula with a surrounding structure. Some of the chronic features that we see in Crohn's disease are the architectural distortion. Now, this is an important point because when we define chronicity histologically, one of the main things that we refer to is distortion of the gland or the crypt architecture. So instead of the rounded tubular structures that we saw in the first picture, right here, you see these rounded crypts. When you get chronic inflammation, the crypts will start to branch. They will become horizontal. Their spaces will become uneven, and that's what we mean by architectural distortion. Other features, there will be heavy basal lymphoplasmacytosis. We get crypt abscesses, which are collections of neutrophils. Now, Paneth cells, these are normal structures within the terminal ileum, but one of the features of chronic disease is hyperplasia of these eosinophilic cells within the crypts. These produce antimicrobial peptides, and that's why they undergo hyperplasia. Or when you see them in the left colon, they are a sign of metaplasia. These mucinous glands that can develop in the ileum, these are known as pyloric type glands, which are similar to those in the stomach. This is also a sign of adaptive metaplastic change that participates in repair. Remember the cobblestone appearance that we mentioned? Sometimes it becomes so prominent that it forms a pseudopolyp. So it's not a true neoplastic polyp with a mutation. It's just an elevated, uninvolved portion of the mucosa with surrounding ulceration. And this is how we see it under the microscope. Now, one of the hallmark features of Crohn's disease is the development of granulomas. Granulomas are only present in about 50% of resection specimens and only about 30% of endoscopic biopsy specimens. So we do not depend on them for a diagnosis of Crohn's disease, but they will be a nice add or a nice touch if they're present. The granulomas in Crohn's are usually compact, small, they're not very large or confluent, and they don't have central necrosis or suppuration. Other features that we see in Crohn's is fibrosis of the submucosa. This is one of the, and neuromuscular hyperplasia. These are the causes of the strictures that we saw grossly. One of the other hallmark features of Crohn's disease that we only see in resection specimens are transmural lymphoid infiltrates. So these are lymphoid follicles, and they are found not only in the mucosa, but they also go into the submucosa and into the muscle, and sometimes they're arranged in a linear fashion known as a rosary bead or a string of beads. Okay, so these clear spaces, this is fat. This is the mesenteric fat that creeps along the wall, which we refer to as the creeping fat. So, do we see all of these features within an endoscopic biopsy? No, we don't. We only see the features that are present in the mucosa and in the upper submucosa. So anything deeper than that will only be seen within a resection specimen. And that's why the hallmark features like transmural lymphoid aggregates are not seen on an endoscopic biopsy. And among these features, some of them are major defining features, and the others are just minor secondary supportive features. The major features are the presence of segmental or disease or skip lesions, the fissuring ulcers, the creeping fat that we mentioned, transmural aggregates and granulomas. And as you can see, most of these are features that are only present on a resection specimen, not on an endoscopic biopsy. And that is why with an endoscopic biopsy, we cannot give a specific definitive diagnosis, as I'll come to in a moment. But it's just important to keep in mind, when we say active inflammation, we're referring to neutrophilic activity. So we have neutrophilic inflammation within the crypts, whether it's cryptitis or crypt abscess. When you say chronic inflammation, we don't just mean the presence of chronic inflammatory cells. No, we refer to glandular architectural distortion that I showed in the picture, as well as heavy basal inflammation. So this, yeah, don't need to go over there. So in pathology, for most of the conditions, probably more than 90%, we can give a specific, definitive top-line diagnosis. So I can say adenocarcinoma grade 2. I can say it's a leiomyosarcoma or any other of the conditions that we have. But there are conditions in which you cannot give a specific diagnosis, by design or by nature. Even if you are a pathologist with 50 years of experience, it doesn't change how it is. Why? Because a disease like Crohn's disease has different histologic findings which are not specific for it. It overlaps with other diseases. So that's why the best that we can do is we give a descriptive diagnosis and we say that it's consistent with this condition in the appropriate clinical context. So this is one of those conditions in which the clinician, the radiologist, the endoscopist, and the pathologist keep throwing the ball in, the other ones field it and hoping that they will diagnose it for them. So the top-line diagnoses that I usually use in a biopsy of Crohn's disease, the simplest one, the earliest one would be an erosion with non-specific mixed inflammation. So this would be like the aphthous erosion that you see endoscopically. Then you start to have chronic changes, the glandular distortion, the metaplasia we mentioned. And then you go further down if you have chronic active inflammation with or without granulomas. So the most specific or the most suggestive for Crohn's disease would be a chronic active ileocolitis with granulomatous inflammation or with non-necrotizing granulomas. Now, in resection specimens, if you have active inflammation at the margins, or if you have granulomas within the specimen, these are predictive of recurrence of the disease in some studies, but the data are conflicting. All right, so now we come to the mainly histologic mimics of Crohn's. Now, for ulcerative colitis, there are a few points. First of all, it's usually a colonic disease. It starts usually from the rectum and extends upwards in a continuous fashion. That's not how Crohn's disease works. It usually spares the rectum, and it's a patchy disease or a segmental disease. The second point is that histologically, ulcerative colitis involves mainly the mucosa. It doesn't extend through the entire thickness of the wall, whereas Crohn's disease is a transmural disease, as we saw in the histologic pictures. The third one is you can have upper GI involvement in ulcerative colitis, but it's not as severe as you can see in Crohn's disease, and you don't have perianal disease within ulcerative. Granulomas are not present in ulcerative colitis, and by that I mean the non-necrotizing granulomas that I showed. Well, if we have a damaged crypt, so this is a colonic crypt here, and you see this collection of neutrophils inside, this is a crypt abscess, and you can see it's discontinuous here, so this crypt has been destroyed. Now, as a response to this destruction of the crypt, we get a granuloma. This is not specific for Crohn's disease, and it has no diagnostic value. So it's important, if I note within the report that I have a crypt rupture granuloma, it doesn't mean that it's Crohn's. It could be anything. The involvement of the terminal ileum can occur in ulcerative colitis. It's known as ulcerative colitis-associated ileitis, or previously backwash ileitis. And this is usually limited to the distal part of the terminal ileum. It's usually not as severe as you see in Crohn's disease, and it's mostly just acute inflammation. Okay, we have a variant of Crohn's disease which is known as superficial Crohn's disease or ulcerative colitis-like. We diagnose this only when we have typical Crohn's disease in other segments of the colon or we have granulomas with it. Now, tuberculosis is one of the great mimics of Crohn's disease. It's characterized by circumferential ulcers rather than linear or serpiginous ulcers that we have in Crohn's disease. And it's characterized by more abundant, confluent, larger granulomas, usually associated with central necrosis. What can we do to distinguish them? Because there is overlap, histologic overlap. We can do, from our part, we can do histochemical stains. We can do acid-fast stain for the mycobacteria, but this is not very sensitive. Only about 40–50% of them will detect it. So it's better if you suspect it endoscopically to take a fresh biopsy along with the biopsy that you send to us. You take a biopsy and send it for culture because that's more sensitive, or PCR. So there was some suggestion of an immunohistochemical stain that would highlight the granulomas of TB as opposed to Crohn's disease, but it was shown not to be sensitive or specific, so we don't do it. Okay. These are the granulomas of tuberculosis. You can see these pink rounded collections. They're much more abundant than you see in Crohn's disease. We had a case, there were a lot of granulomas just within the endoscopic biopsy, so we were doubtful that it is Crohn because you usually don't see that many granulomas within a biopsy, and we recommended an infectious workup for it. This is an acid-fast stain. You can see these tiny red structures. These are the organisms. Now, regarding drug injury, NSAID-induced injury can cause aphthous erosions like we see in early Crohn's. They can cause punched-out ulcers. Now, the pattern is different. It doesn't cause a pattern of chronic active ileocolitis histologically that we saw with Crohn's, but it is important to stop NSAIDs before you make a diagnosis. I did a few more. It's important to stop NSAIDs before you make a diagnosis of Crohn's, especially in an asymptomatic patient that you do an ileocolonoscopy and you find a few erosions in the terminal ileum. You shouldn't diagnose Crohn. Usually they do not progress to Crohn's. Okay, let's skip this. Acute infectious colitis has a different histology. It's only active disease. We don't have the chronic changes that we mentioned. But it's important to do stool culture and serology for these. Pseudomembranous colitis, you shouldn't be doing an endoscopy for a patient with pseudomembranous colitis to begin with. You should be diagnosing it clinically and with stool tests. But if you do, if it's an atypical presentation, histologically it's different from Crohn's. We don't have chronic changes. You see that the glands are rounded and nicely ordered. It's only acute inflammation with this volcanic-like ulceration. Regarding Yersinia, this is also one of the mimics of Crohn's disease because it's characterized, it can have all of the histologic features of Crohn's. It can have granulomas. The granulomas are usually suppurative, meaning that there is neutrophilic inflammation within them. So it's important to keep this in mind, especially if you have appendiceal involvement to do the culture and the PCR or the serology for it. It is suggested to be one of the pathogenic causes of Crohn's disease, as in one study it was found in about 30% of patients. Okay, so what about cytomegalovirus? This can complicate Crohn's disease. We can do immunohistochemistry for it, and there's also PCR, so it's relatively easy to distinguish them. Diversion colitis occurs within a segment of bowel. After resection, the distal segment becomes deprived of the stool stream. So it becomes deprived of short-chain fatty acids, and there are alterations in the microbiome. It can have identical histologic features to inflammatory bowel disease, and that is why we need to know the history in this case. Diverticular disease is also identical to inflammatory bowel disease histologically, so we have to know the history that this is restricted to the area of the diverticulum. LGV and syphilis, these are in homosexual males. They can have proctocolitis. We don't need to go over that. Ischemic colitis has a very different histology. It's usually in the watershed areas. There is mucosal necrosis and hyalinization. Behçet syndrome, the patient will have other symptoms of Behçet like oral and genital ulcers, uveitis. And there is some overlap in their treatment modalities. Radiation colitis, the patient will have a history of radiation. You can have some hyalinization of the lamina propria with dilated vascular spaces. And in GVHD, well, the patient will have a history of an allogenic transplant. So yeah, just 1 minute. Allogenic transplant, but it can have some chronic changes like we mentioned. So you see these crypts are distorted, there is branching, there is abnormal orientation, but there will be apoptosis and a positive inflammation with it. So as one last point, it's important to always exclude infections. This is an example from one of our GI pathology textbooks that there was endoscopic suspicion for Crohn. It was a right-sided colitis. There was histologic features of Crohn's, but then the patient was found to have, by culture, was found to have an Aeromonas infection, and that was the cause of it. So take-home messages: Crohn's disease is a multidisciplinary diagnosis. There's no magic bullet for diagnosis. The best supportive histologic diagnosis that we can give is a chronic active ileocolitis with non-necrotizing granulomas. You should always exclude drug-related injury. You should always exclude infections, especially TB and Yersinia, and you should exclude systemic illnesses. And thank you.
Thank you very much, Dr. Rawa. Now, the time for the question and answer. Please, Dr. Muhsin, Dr. Sivan, Dr. Shahla, Dr. Rawa Khosh. ولو حقدني برسالة لي أفكرها. Anyone has a question, please? Dr. Umar.
My question to Dr. Sivan. What about the role of tacrolimus in inflammatory bowel disease? It's not mentioned, I think.
Induction or maintenance according to the guidelines for tacrolimus, and only biologic agent, anti-integrins, and methotrexate in some guidelines has been mentioned to have roles in either induction or maintenance.
Dr. Umar Hamaghalib.
Thank you all for all the presenters. My question is for Dr. Muhsin. Is osteoporosis is due to the side effect of steroid or the disease itself?
Both associated with the both side effects of steroid increase the risk of osteoporosis and decrease bone density, and even disease activities associated with the metabolic derangement.
Thank you.
Dr. Ari.
دستان خوش به پرسیارکم با کاکتور روایا. Really, I'm not doing any more GIT pathology thanks to Dr. Rawa, but I have a question and explanation. First, one point that we struggled with most is the type of the biopsy and the adequacy of the biopsy. Sometimes the biopsy is very superficial and it's not adequate for proper diagnosis, and this part will be on the endoscopist side. This is an explanation. And number two, sometimes we had to use terms like in keeping with, consistent with, in favor. You didn't talk about the value of these terms actually. And this is very important for the clinician and the endoscopists to be familiar with. Thank you.
Thank you. This is working now. Thank you for your comments, Dr. Ari. Regarding the adequacy of the biopsies, I think they're mostly adequate. That's what we can expect. We can only have the mucosa and only part of the submucosa. We cannot go deeper than that. So it's mostly representative or mostly adequate. If it's not, then we can write a comment that the interpretation that we gave is limited by the adequacy of the biopsy. With regards to the terms like consistent or suggestive, I touched upon that when I talked about the fact that we cannot give a specific diagnosis in the case of Crohn's disease. We can describe the pattern and say that it's consistent. As regards the difference between terms like consistent, suggestive, favoring, this is mostly subjective. So for me, for example, if I say suggestive, I don't want to commit, so I say, well, it may be that. If I say consistent, then I'm a bit more confident, or favoring. But I think this is something subjective. It's not mentioned anywhere, and it depends on local practice and the pathologist's preference. Thank you.
Dr. Herman.
Thank you for all of you. I have a question for Dr. Muhsin. Regarding the indication of cholecystectomy in gallbladder polyp related to inflammatory disease, bowel disease.
Yeah.
If they're related to the extension of the disease, time of the diagnosis, age of the patient, if they're related, this is ulcerative or Crohn's, or all of the two types of the inflammatory bowel disease, whenever we have the gallbladder polyp, despite the size of the polyp, it has indication for cholecystectomy.
Yeah, as I mentioned, the candidate for cholecystectomy should be low down. The threshold for cholecystectomy in the patient with the gallbladder polyps should be low down. As you know, the indication of gallbladder polyp should be above 10 millimeters in the non-IBD patient. In IBD patient, even 7 millimeter, even less than that, if you suspect, should send for cholecystectomy, which is not related to the age limited in the elderly patient, in young patient. Even in young patient should be more aggressive, because the life expectancy is suspect more long life. If you suspect in a patient with IBD with a gallbladder polyp, even if less than 10 millimeters, should send for cholecystectomy, which is not related to the age.
Not related to the extension of the disease.
No.
Newly diagnosis or how many years on?
Not related to the extension of the disease, and not related even to the activity of the disease. For example, if the IBD patient is controlled and the patient have gallbladder polyp,
yes,
it's not related to the disease activity. I mean, the patient may go to malignancy without disease activity.
Okay, thank you.
Dr. Habib, this is the last question.
My question is for Dr. Rawa. What's indeterminate colitis? Sometimes we send the patient for colonoscopy and biopsy, come back. Ulcerative colitis or Crohn's disease, it's easy, it's straightforward, but sometimes it's come back with indeterminate colitis.
Jamal, okay. Thank you for your question, Dr. Habib. I think nobody knows what indeterminate colitis is because there are different criteria used by different people. You use it when there are overlapping features. Say you have a continuous rectal disease extending upwards, and then the inflammation, when you get a resection, you have transmural lymphoid aggregates, or when you have granulomas. So there are the combined features of ulcerative and Crohn's. In that case, it may be prudent to use indeterminate. So we shouldn't be using it as pathologists on an endoscopic biopsy. You shouldn't be getting that in your reports. It should be a clinical, or again, a combined diagnosis that usually happens later in the course of the disease, usually when you get a resection, or when you have mismatching endoscopic and histologic features between ulcerative and Crohn. So as I said, as pathologists, we don't give the specific diagnosis, we suggest it. But for something like indeterminate, I don't think we should be making that diagnosis at all. Only in later in the course of the disease or when you get a resection.
I think we have another question, Dr. Hoshman. Dr. Shawash, das halabrin azana.
Dr. I have a question. You said in ulcerative colitis there is non-specific granuloma. How you differentiate this granuloma from granuloma of the Crohn's disease? And there is in terminal ileum, you said there is inactive chronic ileitis and active chronic ileitis. How you differentiate between these two?
Okay,
thank you.
I mentioned that the granulomas that you can see in ulcerative colitis are related to crypt rupture. So that means there is a gland or a crypt that is destroyed by inflammation, and then there is a granulomatous response to that. We do not count that as a Crohn-specific granuloma. So I will not even mention it in the diagnosis line. I will just bury it in the description so that nobody sees it, because it has no diagnostic value. Or I will explain it in a comment that this has no diagnostic value. The granulomas in Crohn's disease are not related to crypt rupture. And I'll make sure to point that out within my report so that I say that it has diagnostic value. With regards to active and chronic, I mentioned that for active inflammation, there are criteria that we use, mainly neutrophilic activity. So if I have cryptitis, if I have crypt abscess, if I have erosion with it, then that's active disease. But if I don't have that, I just have architectural distortion, I have some mucosal muscularis mucosa hyperplasia, or some basal lymphoplasmacytosis. I'll say this is chronic ileitis, but I don't have features of activity, which is neutrophilic cryptitis. That's the difference.
Dr. Shaho.
Thank you. Thank you, dear presenters, for your nice presentations. Dr. Muhsin, I have one question. You talked about the thyroiditis in Crohn's disease as an extraintestinal manifestation. Is it autoimmune thyroiditis? I mean by autoimmune, is this hyperthyroidism or hypothyroidism, or there will be positivity of the autoimmune antibodies like TRAB or TPO? And what could be the treatment of the thyroiditis? Is it treated by the treating of the Crohn's disease, or needs the special treatment?
I think it's not, I'm sure about the answers. I think autoimmune related.
Yes. So maybe hyperthyroidism or hypothyroidism?
Maybe hypothyroidism, maybe hypothyroidism. Most probably autoimmune based.
Thank you.
Thank you very much. Dr. Choman, this will be a last question. مجالي الثاني. سيدي ملولا ناكم.
Regarding MRE, how long fasting for preparation need? For MRE, regarding fasting, how long?
From water, he can take water, and then you give spasmolytic agent plus the hyperosmolar. First of all, the hyperosmolar, 500 to 100 ml hyperosmolar solution, and you should have an idea about if the patient have a bowel resection or not, because at that time you should reduce, for example, the amount of the solution, or even reduce the amount of the time. That is, you give a 45 minutes when he take the oral solution to reach the small bowel. So you should adjust all of these parameters, plus this spasmolytic agent, it's important. I don't go through the technique well, because it may be boring for our friends, but one should adjust the technique very well in MRE, especially if you are looking for estimating the score. These are important. Even without that, you should try to do it in that way. 70 second and 7 minute contrast enhancement in order to assess whether we have a component of inflammation or fibrosis through taking the percentage of the gain enhancement, as Ramuella proved it in his study. Thank you.
Thank you very much. Thank you, doctors and teachers. Next talk will be a talk of Dr. Hiwa, President of Kurdistan Association of Gastroenterology and Hepatology. He will talk about the role of third space in